The phenomenon of seizures in pediatric populations represents one of the most disconcerting experiences a parent might encounter. When a child suddenly manifests tonic-clonic movements, displays altered consciousness, or exhibits blank staring episodes, one naturally experiences a profound sense of temporal suspension. Yet it behooves us to recognize that not every seizure portends chronic neurological dysfunction. Indeed, a considerable proportion of such episodes constitute transient manifestations of the developing brain's inherent vulnerability to electrical dysregulation. This comprehensive examination shall systematically explore the spectrum of seizure disorders and epileptic syndromes presenting in childhood, progressing methodically from the most prevalent and typically benign conditions to those requiring more intensive therapeutic intervention. We commence with febrile seizures, those temperature-induced episodes that affect a substantial minority of young children, before advancing through the established pediatric epilepsies, including benign Rolandic epilepsy, and ultimately addressing the more complex syndromes such as West, Dravet, and Lennox-Gastaut. Our objective remains pedagogical rather than alarmist, to furnish parents and caregivers with a measured, evidence-based understanding of these conditions, their diagnostic pathways, and contemporary therapeutic modalities. We commence our investigation with febrile seizures, which constitute the most frequently encountered seizure type in the pediatric demographic. These episodes typically manifest between 6 months and 5 years of age, precipitated by pyrexia, often coinciding with the onset of viral infections. Epidemiological data suggest that approximately 5% of children shall experience at least one such episode, whilst the precise pathophysiological mechanisms remain incompletely elucidated. Current neuroscientific understanding posits that the immature central nervous system exhibits heightened excitability, rendering it susceptible to abnormal electrical discharges when confronted with rapid temperature elevation. It bears emphasizing that febrile seizures do not constitute epilepsy per se, nor do they typically presage the subsequent development of epileptic disorders. One must distinguish between simple and complex presentations. Simple febrile seizures, characteristically brief, typically under 5 minutes, involve bilateral motor manifestations. Complex febrile seizures, conversely, demonstrate prolonged duration, recurrence within 24 hours, or focal features. Diagnostic approaches rely primarily upon careful clinical history-taking and the systematic exclusion of more serious etiologies, particularly meningitis. Routine investigative procedures are seldom warranted in uncomplicated cases. Management remains refreshingly straightforward, ensuring the child's safety during the icetal phase, appropriate pyrexia management, and timely medical consultation. Emergency pharmaceutical intervention is reserved for exceptional circumstances. The prognosis remains overwhelmingly favorable, with most children experiencing complete resolution by their 6th year. When seizures manifest in the absence of pyrexia or other identifiable precipitants recurring with concerning regularity, one must consider the diagnosis of epilepsy. It behooves us to recognize that pediatric epilepsy represents not a singular entity, but rather a heterogeneous constellation of syndromes, each characterized by distinctive patterns of onset, electroencephalographic signatures, and prognostic trajectories. The spectrum encompasses self-limited conditions that resolve spontaneously with maturation, alongside more intractable syndromes necessitating sustained therapeutic intervention. Let us proceed to examine several paradigmatic examples. Amongst the most prevalent childhood epilepsies, benign Rolandic epilepsy, now termed self-limited epilepsy with centrotemporal spikes in contemporary nomenclature, typically emerges between 3 and 13 years of age, frequently during somnolent states. Seizures characteristically involve hemifacial motor phenomena, siluria, and dysarthria. The designation benign reflects the condition's generally favorable trajectory, with spontaneous resolution typically occurring by adolescence. Affected children generally demonstrate normal neurodevelopmental progression, many experiencing merely a handful of seizures before complete remission. Electroencephalographic studies reveal pathognomonic sharp-wave discharges localized to the Rolandic cortex. Therapeutic intervention may prove unnecessary when seizures remain infrequent. Should nocturnal events or academic disruption necessitate treatment, carbamazepine or levetiracetam represent first-line pharmaceutical options. parents should derive considerable reassurance from the virtual certainty of eventual resolution. We now direct our attention to more complex epileptic encephalopathies. West syndrome, alternatively designated infantile spasms, typically manifests within the first year of life. Parents observe sudden repetitive flexor or extensor spasms, the infant's extremities jerking anteriorly or the trunk flexing at the waist. These episodes characteristically occur in clusters, particularly upon awakening. Electroencephalographic examination reveals the chaotic, high-amplitude pattern termed hypsarrhythmia. Etiological factors demonstrate considerable heterogeneity. Some infants harbor genetic mutations, structural brain abnormalities, or evidence of previous neurological insult, whilst others present cryptogenically. Contemporary therapeutic approaches encompass adrenocorticotropic hormone, corticosteroids, or vigabatrin. The imperative for prompt recognition and intervention cannot be overstated, as uncontrolled spasms correlate with adverse neurodevelopmental outcomes. While some children face persistent challenges, early therapeutic intervention demonstrably improves prognostic trajectories. Dravet syndrome represents a rare yet severe epileptic encephalopathy, often heralded by prolonged febrile seizures within the first year of life. Subsequently, affected children develop polymorphic seizure patterns, encompassing generalized tonic-clonic, myoclonic, and focal seizures. The majority of cases demonstrate mutations in the SCN1A gene, encoding a voltage-gated sodium channel crucial for neuronal excitability regulation. This molecular insight has revolutionized our understanding of the syndrome's pathophysiology and its characteristic pharmacoresistance. Recent therapeutic advances, including stiripentol, cannabidiol, and fenfluramine, have engendered cautious optimism amongst affected families. Comprehensive supportive care, incorporating physical, occupational, and speech therapies, remains integral to optimizing quality of life. Lennox-Gastaut syndrome, typically emerging between 2 and 6 years, presents formidable therapeutic challenges. Children experience multiple seizure types, tonic seizures, atonic drop attacks, and atypical absences, often accompanied by cognitive impairment and behavioral difficulties. Electroencephalography demonstrates the characteristic slow spike and wave pattern. Management invariably requires polypharmacy, whilst non-pharmacological interventions, the ketogenic diet, vagus nerve stimulation, or selective surgical procedures, merit consideration in refractory cases. Despite therapeutic challenges, ongoing research continues to expand our armamentarium. Childhood absence epilepsy warrants brief mention here, characterized by subtle seizures manifesting as transient lapses in awareness, often accompanied by eyelid myoclonia. For those seeking comprehensive examination of this particular syndrome, we direct viewers to our previously published detailed analysis available on this channel. Whilst certain conditions discussed herein present considerable challenges, one must emphasize that numerous children with epilepsy achieve fulfilling, productive lives. Contemporary advances in molecular genetics, neuroimaging modalities, and pharmaceutical development have substantially enhanced our therapeutic capabilities. International epilepsy foundations and support networks provide invaluable resources for affected families. In summation, febrile seizures, whilst alarming, typically follow benign trajectories. Certain epilepsies, benign Rolandic and absence epilepsy amongst them, demonstrate self-limited courses with excellent prognoses. Others, including West, Dravet, and Lennox-Gastaut syndromes, necessitate specialized multidisciplinary care. The paramount considerations remain timely recognition, accurate diagnosis, and comprehensive support enabling children to flourish despite neurological challenges. Contemporary medicine, bolstered by expanding scientific understanding, renders the outlook for children with epilepsy more promising than ever before.